Hello, my name is Nihar Parikh, and on behalf of my colleagues at the Northwestern University Feinberg School of Medicine, I will be discussing our recent article entitled A Cost-Efficacy Decision Analysis of Prophylactic Clip Placement After Endoscopic Removal of Large Polyps from Clinical Gastroenterology and Hepatology. Delayed lower GI bleeding after endoscopy can cause significant morbidity, which can lead to hospital admission, blood transfusion, and need for repeat procedures. One strategy endoscopists have employed to mitigate this risk is the placement of prophylactic clips at the base of the polyp site. The idea for this study came from our clinical observation that clips were being used for preventative purposes. However, we had a good deal of uncertainty whether this was the best use of resources. Therefore, we decided to conduct this study. The aim of this study was to determine if routine post-polypectomy clip placement is a cost-effective strategy. We also wanted to determine if varying the bleeding risk for a patient with higher propensity to bleed, such as those patients who are set to resume antiplatelet or anticoagulation therapy after polypectomy, had any impact on the analysis. To conduct this study, we constructed a decision analysis that you can see here, modeling post-polypectomy bleeding with and without clip placement. We performed a meta-analysis of the literature to obtain our probabilities of bleeding after polypectomy and the effectiveness of the clip in the reduction of that bleeding. We made estimations on patient quality of life so that we could calculate the quality of life utility. We obtained cost data based on CMS reimbursement. Our cost of effectiveness threshold was $100,000 per quality of life year gained. The base case of our analysis was a 50-year-old patient who was undergoing their index colonoscopy and had a 1 to 1.5 centimeter pedunculated polyp removed. Our findings showed that the probability of post-polypectomy bleeding would have to be above about 2% to have an acceptable incremental cost-effectiveness ratio. And for our base case, the delayed post-polypectomy bleeding rate was only 0.64%. Therefore, it was not a cost-effective strategy. However, we did find that patients on antiplatelet therapy or on anticoagulation therapy had a bleeding rate greater than 2%, and therefore clip placement may be cost-effectiveness in this situation. We performed several two-way sensitivity analyses varying the bleeding rate without clip by a percentage of clip reduction in bleeding with clip placement. The cost of lower gastrointestinal bleeding, the cost of the clip itself, the number of clips placed, the reduction in utility for patients with lower GI bleeding, and the probability from incurring harm from the clip itself being placed, which was a theoretical risk. As we can see from the graphs, the analysis was sensitive to clip effectiveness, cost of both the lower GI bleed and the clip, and the number of clips placed. In conclusion, our analysis showed that prophylactic clip placement may be a cost-effective strategy for those patients with an increased risk of bleeding after removal of large polyps, such as those patients on anticoagulation or antiplatelet therapy. However, we must stress that these results must be confirmed in a larger controlled trial before being applied clinically. I thank you for tuning in and your attention. Feel free to contact me with any questions.